Okay, hello, good morning. I am Lien Deschuytere. I'm the current Rhinology Fellow in Deschuytere Hospital, and I will be giving you an update on anosmia today. So, we saw a 33-year-old male patient with an 11-month history of anosmia following a COVID-19 infection. On first visit, he presented with an acute right-sided sinusitis with pus, with no other intranasal abnormalities. CT scan confirmed the right-sided sinusitis, but didn't show any other abnormalities. We treated him with antibiotics, nasal douches, and decongestive spray. On a follow-up visit, however, he still complained of anosmia despite correct treatment. On examination, there were no abnormalities, and also MRI seemed to be normal. The olfactory bulb seemed to be normal, as well as the olfactory tract. So after discussion with the patient, we started an intranasal PRP infiltration. This is actually a very new option in the treatment of anosmia, and it's basically a platelet-rich plasma infiltration, which is an autologous blood product with supraphysiologic concentrations of platelets and growth factors, and it's believed to help in the regeneration of the olfactory neuroepithelium. So practically, you draw a peripheral blood sample of the patient, you centrifuge this sample, and after removal of the supernatant, which you can see on this picture here, you draw the PRP into the syringe, and you inject it submucosally into the olfactory cleft region on both sides. As you can see in this video, this was the actual patient. So it's 1 milliliter you inject on both sides, and you can repeat this injection a couple of times. So since the COVID-19 pandemic, we've been seeing more and more patients suffering from long-term anosmia, and this also reflects in research. There has been a lot of research about new treatment options, new medications, new ways to help these patients. And today I will try to give you an update on what's useful and what isn't useful. So to give you some practical tips for your practice. So we'll start with some introductions, some definitions. So hyposmia is a reduced sense of smell, whereas anosmia is a complete absence of smell. Hyperosmia is a heightened sensitivity to odors. So for example, when you're hungry. And dysosmia is an altered perception of odors. Phantosmia are olfactory hallucinations, and parosmia is a distorted perception of odors, for example, cacosmia. When we jump into pathophysiology, we concentrate on the olfactory neuroepithelium, which can be found around the cribriform plate of the ethmoid bone, very high up in the nose. So when an odorant enters the nose, it gets dissolved into the mucus layer, which overlies this epithelium. It attaches to an odorant body. In contact to the olfactory receptor cell. So the olfactory neuroepithelium contains about 50 million olfactory sensory neurons, and each neuron expresses one type of olfactory receptors towards the nasal cavity. So when an odorant connects to these receptors, it causes a depolarization of the cell. And this depolarization goes along the axon through the cribriform plate into the glomerulus in the olfactory bulb, where it synapses with mitral and tuft cells into the olfactory tract to the olfactory cortex. So when we do a workup for these patients, it's very important to do a thorough history where you characterize the type of smell loss, the laterality, the onset, the precipitating events, associated symptoms, occupational exposures, smoking, medications, and many others. When you do the examination, you perform a rhinologic examination, an oral evaluation, and also a neurological assessment for possible associated effects. For diagnostic testing, you can use standardized smell tests, such as the upset test or the sniffing sticks test. Those are both commercially available tests you can buy. There are also some chemosensory tests, for example, the butanol threshold test or the odor identification and trigeminal function test, but they are quite time-consuming to perform in practice. Imaging is not routinely performed, You can perform an MRI for patients with a history of head trauma, neurological abnormalities, or suspicion of malignancy. And for suspected sinus disease and skull-base evaluation, you can perform a CT scan. Laboratory tests are usually necessary, but sometimes can be helpful, for example, to perform a thyroid profile function or hypoglycemic levels. Allergy testing can be performed if suspected allergic rhinitis. For the differential diagnosis, there are in essence three main causes you have to consider, being sinonasal disease, post-infectious causes, or post-traumatic causes. For sinonasal disease, we think of chronic rhinosinusitis with or without nasal polyps, allergic rhinitis, and less common esthesioneuroblastoma. As you can see on this MRI, it's quite an extensive one. The post-infectious causes we know very well, so they're associated with acute viral upper respiratory tract infections. We've seen a lot of those during the COVID-19 pandemic. Post-traumatic causes are mostly head traumas, so they can cause damage to the nasal passages, displacement or disruption of olfactory axons, or contusion or destruction of the olfactory bulb or cortex. Other possible causes can be central nervous system disorders such as neurodegenerative disorders, ischemia, Kalman syndrome, and others. Occupational and environmental exposure to various toxins can also cause anosmia, as well as tobacco use. There are also certain medications that can cause anosmia, such as beta blockers, calcium channel blockers, ACE inhibitors, intranasal cocaine use, and many, many others. Diabetes mellitus and hypothyroidism have also been associated with hyposmia, anosmia, and even parosmia. So you have to keep this in mind. And lastly, also normal aging is associated with a decline in olfactory function due to various physiological changes. So it must not be forgotten that this also can be a normal process. So now we come to the treatment part. So for the treatment, it's actually very important to address the treatable underlying causes first and to emphasize risk and safety message to the patients, because when they lose their smell, they are unable to smell smoke or to smell food that has expired, etc. We also always advise smoking cessation because it can cause anosmia, so it's important to stress this one. When we go further on to the treatments, we'll go cause by cause. So for obstructive nasal disease, we try to address the underlying cause and remove obstruction. So for chronic rhinosinusitis, this can be corticosteroids, antibiotics, surgery, or biologicals if available. For allergic rhinitis, we try to do allergen avoidance, use antihistamines, intranasal steroids, or immunotherapy. For head trauma, the presence and severity of the olfactory dysfunction depends on the severity of the head trauma, the duration of the post-traumatic amnesia, injuries, and age. There can be a conductive or a neurosensory smell loss. Conductive causes can often be treated, but unfortunately, the majority of neurosensory deficits do not recover, and there is also no effective proven treatment so far for these cases. Neurodegenerative disorders are often very difficult to treat, and the only proven treatment so far is olfactory training. So that's the only one you can offer to these patients. And the last cause is the post-infectious cause. As I've mentioned before, there has been a lot of research in recent years, so I'll try to summarize the medications that have been tried and which ones are useful and which one aren't. So you can see here that there's a lot of treatments that has been tried, and I will try to go over them step by step and give you some practical summary in the end. So we start with conservative management. You have to bear in mind that at least 1/3 of patients will spontaneously recover. And this can be even more because there are also many, many patients that never present to a doctor with complaint of smell loss. So just keep this in mind, and also advise smoking cessation every time. The second one is olfactory training. Multiple studies have demonstrated a positive effect, and the longer the treatment, the better the outcomes. the olfactory epithelium in mammals is very unique because it has a sort of regeneration capacity. And olfactory training tries to improve these characteristics by regularly stimulating these neurons. So in classic olfactory training, you use a 5-minute exposure to 4 different odors twice a day. You do this at least 12 weeks or more. But now there has also been a modified olfactory training where you start with the first 12 weeks, then change to another second set of odorants for 12 weeks, and even a third set of odorants. For these sets, you can buy commercially available sets, but they are quite expensive. So you can also advise patients to go to the supermarket, buy shampoos with different odors, spices, etc., just to try to stimulate these neurons. Corticosteroids is something we use very often. Several studies have shown a positive effect. This is presumably mainly due to the effect on the sinonasal inflammation and not really because of any additive effects to the olfactory neuroepithelium. We can give this oral, but there are some side effects you have to take and bear in mind, or you can give a local administration. Another option is a topical administration of sodium citrate. So by sequestering calcium ions, the free mucosal calcium in the olfactory cleft reduces, leading to a reduction in negative feedback and increased sensitivity to odorants. This has been shown to improve olfactory performance, but only for short durations, so up to 2 or 3 hours. So it is an option, but it's only short term. Vitamin A plays a key role in the neurogenesis and recovery of olfactory neuroepithelium, but studies have shown some contradictory results. So there's no shown effect with oral administration, but with topical administration, there has been shown significant clinical improvement. So the next one is the platelet-rich plasma. So as we have talked about before, so this is an autologous blood product with supraphysiological concentrations of platelets and growth factors. This promotes regeneration of the peripheral nerves. And it has first been studied by the working group of Sarah Patel et al. In 2020. And they confirmed their positive effects in a randomized controlled trial in 2022. And by now, even other single-arm clinical studies have shown a positive effect. So this is actually a very promising treatment towards the future. And in the randomized controlled trial, they give 3 injections at week 0, 2, and 4. But this has to be studied yet. There hasn't been a lot of studies about how many times you have to give it, how long you have to wait for effect. So that will possibly be coming in the next few years. Alpha-lipoic acid is an antioxidant and stimulator of nerve growth factor substance P and neuropeptide Y. It has been studied, but only in one uncontrolled, non-blinded study, where it has shown a significant improvement, but it needs further investigation to be used clinically. So caroverine is an aspartate antagonist. It's suggested to prevent glutamatergic neurotoxicity, but it has also been studied only in one trial, so needs some more confirmation. Topical insulin has also been studied, but only in a very, very small study with only 10 patients. So as well, this also needs some more investigations. Theophylline is believed to increase cyclic adenosine and guanosine monophosphate in nasal secretions. This may aid in the regeneration of olfactory neuroepithelium. But the evidence so far is quite inconclusive with positive and negative effects. So for the moment, not really advised. There also has been a study about traditional Chinese acupuncture that showed a significant improvement on anosmia. But unfortunately, the study had a high bias and reanalysis of the data could not find any significant improvement. Zinc sulfate is sometimes used in taste disorders, but in hyposmia or anosmia, it hasn't shown any significant improvement so far. Minocycline is has some anti-apoptotic properties. It's used as a neuroprotective treatment in various neurological disorders. But a prospective placebo-controlled, double-blind, randomized controlled trial could not show any difference compared to placebo. So ginkgo biloba is another one. This improves olfactory neurogenesis in mouse models, but also hasn't been shown any effect in humans. So to summarize, olfactory training is highly recommended. Multiple studies have shown a positive effect, so it's definitely something to advise to your patients. Other things you can try are systemical or topical corticosteroids, topical use of sodium citrate, vitamin A and PRP infiltrations. Unfortunately, all other options are either non-effective or just haven't been studied enough. So not yet ready. To conclude, so for anosmia, a thorough workup is very important to find possible underlying causes because the treatment is very etiology driven. Never forget that more than 1/3 of patients will have spontaneous recovery regardless of the cause. This can take up to 12 months, so you have to tell this to your patients. And in post-infectious causes, olfactory training is strongly advised. You can try oral intranasal corticosteroids. You can try intranasal vitamin A. You can give patients sodium citrate nasal spray, but this works only very short term. So you advise them to take it just before meals so they can smell their meal. So this might help. And you can also try the platelet-rich plasma infiltrations. So these are my references, and I am more than happy to answer any questions.
Thank you, Lien, for that fantastic talk. It's a great summary for those of us getting to exams. So thank you very much. Are there any questions from the panel?
Hi, Shavina.
Hello, hi.
This is Dennis. Just a quick question. First, thank you for the update on anosmia. This is really comprehensive, and it's giving us a very good update on the progress that has been made on the management of these challenges. But for the sake of MDT on these cases, has there been any found role of involving the psychiatrist, especially for the patient with cacosmias?
Yes, it is actually advised to contact your psychiatrist if you have a feeling that there might be something else, because there's a lot of psychiatric disorders that are associated with parosmia and cacosmia, indeed. Yeah.
Hello?
Hi.
Can you hear me?
Yes, Tinani, we can. Do you have a question?
Yeah, it's just a quick question. First of all, it was a very good presentation. Thank you so much for that presentation. I just want to ask, I'm an audiologist, I've been working closely with the ENT as well. So, but I've been, I think I have anosmia. I think I was born with it. So I wanted to find out if it's congenital, because I've never smelled. I don't smell.
Yeah, there are some congenital disorders, for example, the Kalman syndrome, but I assume you'll have to do a genetic analysis to be sure about this one.
Is it? Okay.
Yes.
Oh, okay, no, I will consult with the ENTs as well.
Okay, perfect.
Thank you so much.
You're welcome.
Are there any other questions from the panel or comments? So we'll hear something in the chat.
Thanks for it.
Yeah. Okay, so if there's no other questions or comments, thank you everybody for joining us today. And then we will see you on Friday for our next discussion. Have a good day. Bye.